My name is Vlad Ratziu. I'm a hepatologist working in Paris and specialized in liver diseases with a particular interest in NASH and liver fibrosis. So the chapter for the supplement of Journal of Hepatology is about defining the clinical rationale for the endpoints in clinical trials. It is very important to define with a big deal of precision the endpoints in clinical trials because the randomized clinical trials follow a very rigid format, and it is important in order to compare results between studies, but also in order to gain information about what the next step should be in terms of clinical development to very precisely define what you want to achieve with each particular trial. And then, of course, there are trials that are very short in duration, and there are trials that are much longer, and you don't look at the same things when you test the molecules in these different contexts. What we want to understand, first of all, in terms of endpoints, is whether a drug has the pharmacodynamic effect and the clinical and biological effect that it's supposed to have based on its mode of action. And that is usually achieved within short-term clinical trials. But then what you want to know is whether you can achieve some endpoints that are predictive of a clinical benefit in the long run. And those are mostly the endpoints that are used in registration trials or at least in late phase trials. So there are different outcomes and different endpoints that depend on what stage of development a molecule is in. And all of these need to be defined, sometimes based on the mode of action of a drug, since the clinical benefit of a drug, at least in the short term, is dependent on how it works and what particular pathways it improves. The overall objective in treating these patients is to avoid their progression to cirrhosis, because we know that cirrhosis is the state of the liver disease that is correlated with complications, morbidity, and death. But demonstrating a reduction in the progression to cirrhosis can take a lot of time. So therefore, you need indicators that you're on the right path with a given molecule, but within a shorter time frame, so that you can first demonstrate that you act on a surrogate that is linked to the final outcome, which is progression to cirrhosis. And those two particular surrogates that have been now accepted by the community that seem to be, at least this is what we believe now, that seem to be linked to the progression of cirrhosis are the disappearance or the resolution or the clearance of steatohepatitis and the regression of fibrosis. So the way the clinical trials, at least the ones in late stage of development, are built is that we first try to achieve those two endpoints, so resolution of NASH or regression of fibrosis, or both, and then try to demonstrate with continued exposure to the drug that people that did achieve those endpoints will also experience less progression to cirrhosis and hopefully less clinical complications of cirrhosis. So this is how the phase 3 registrational trials are based now, and the article will try to understand a bit more in depth the implications of achieving those particular surrogates, whether they can be achieved within a relatively short time frame compatible with clinical trials, and how much do they really predict the long-term outcome that is of interest in terms of overall health benefit.